and welcome to our Werfen Acute Care webinar on the impact of hemolysis on patient management in point of care whole blood samples. My name is Bev Straker and I am the GEM Product Manager for the UK for Werfen, and I have the pleasure of welcoming you all and introducing today's session and speakers. In today's session, we have 4 expert speakers and 4 very different views of how hemolysis detection at the point of care will really help patient management. Our speakers will discuss the introduction of hemolysis detection at the point of care. They'll discuss optimising patient care and safety in both ED and NICU with integrated hemolysis detection. And we will also have insights on hemolysis prevalence and its effects hospital-wide. I have the great pleasure of introducing our clinical speakers today. We have a Dr. Salvagno, who is the Professor of Clinical Biochemistry and Clinical Laboratory Director from Verona in Italy. We have Dr. Neff, who is a Professor of Emergency Medicine from Utah. We have Dr. Hoppenz, who is the Head of Neonatology and Paediatric Intensive Care from Cologne in Germany. And we have Dr. Tacker, who is a clinical professor of pathology and also Associate Medical Director of Clinical Laboratories from West Virginia, USA. Just for your reference, these are the personal disclosures for each of our speakers in today's webinar. So in today's agenda, we begin with Dr. Salvagno, who will present on hemolysis prevalence and impact in whole blood potassium testing. We will then follow with Dr. Neff, who will discuss the impact of hemolysis on patient care in the emergency department. This will be followed by Dr. Hoppenz, who will then discuss the impact of hemolysis on patient care in the neonatal intensive care environment. And then finally, we'll have Dr. Tacker, who will share with us a medical director's perspective of implementing hemolysis detection for point of care. We've a really lovely group of speakers today, and we really hope that you enjoyed the talks and look forward to the session. Thank you very much.
Hello, everyone. It's my great pleasure to be here to talk about hemolysis and the impact of hemolysis on potassium and current challenges in point-of-care testing. My name is Gianluca Salvagno. I am full professor of clinical biochemistry at the University of Verona, and I work with Professor Lippi, that is my boss, in the field of pre-analytical phase for a long time. Today we will see what happens when we have hemolysis inside the sample. Unfortunately, hemolysis is a condition not completely recognized but some kind of healthcare workers, because it's very difficult to watch it. What is hemolysis? Hemolysis is conventionally defined as a generalized process of injury to red blood cells, which is usually reflected by the presence of increased concentration of cell-free hemoglobin in serum or plasma. The term hemolysis doesn't distinguish between clinical and artificial cases. What happens when we have for clinical condition, for example, anemia and other hemolytic anemia, we have some kind of red blood cells that are destroyed, for example, by antibody. And what happens? We have all amount of cytoplasma inside the cell that go out. Not only hemoglobin, but also we have outside enzyme, protein, ions, and whatever is inside go outside. For that reason, when we have hemolysis, we change the composition of the plasma and we are able to influence our sample. When we see also we have artificial cause of hemolysis. During the pre-analytical phase, the most important is during the blood collection, because during the blood collection, we have some kind of force that are able to destroy completely a little part of red blood cells, and the amount inside go outside. For that reason, what happens in the plasma? You can watch here, in the left you have a normal plasma without or very low level. For a technical reason, we have the left side very low level of hemolysis without influence on the composition of enzyme, iron, protein, carbohydrates. In the middle, you can see that from the left to the right side, we have increase of the color. The increase in the color is due to, for example, about the hemoglobin. Hemoglobin changed the color to the red color, and we can see the grew in the amount of hemoglobin that you can see at the bottom here in gram. We have exceeded from 0.5 to 5.225 grams of hemoglobin. We have the increase of the color. The column became red because hemoglobin inside we have iron, and the iron usually give the color red. But you can see also that hemoglobin grew, but not only hemoglobin, but also other component inside. Here, for that reason, we have an impact of hemolysis in all settings of clinical, especially in acute care setting. Because in the acute care setting, we have a huge amount of literature. Here we have some data from the published by colleagues from US that describe the increased amount of potassium due to hemolysis. For that reason, we are not able to distinguish the hemolysis by using potassium, because we can have for patients with low level of hypokalemia, for example, when we have potassium below 3.5, but inside we can have hemolysis also, because, for example, the patient could be low level of potassium, for example, 1.5 or 2, that increase due to hemolysis. What is important, the key concept of these slides, is that we can have hemolysis at all levels of potassium, and it is not possible to distinguish hemolytic sample by using only potassium level. For that reason, we can see that we have increase in the emergency department, especially in cardiac, medical, surgical, where we have is difficult for the number of sample, the kind of sample, especially when we take the sample in acute condition. Unfortunately, hemolyzed sample, they arrive at 10% are usually hemolytic sample, but in the emergency department, you can see that we arrive at 20% of sample. Then is hemolysis have an impact on sample and on the patient management, because for that reason we have seen there are a lot of paper that describe that we have around 30% of cases where due to hyperkalemia, mistaken diagnosis, because the central question is about the quality of the sample. When we perform arterial blood gas, we are not able to perform centrifugation, and it's difficult to evaluate the level of hemolysis until now. For that reason, when we have different kind of hyperkalemia or pseudo-hyperkalemia, these have there are consequences for the unnecessary follow-up, delayed treatments, or inadequate intervention. What is really true that we need to know the quality of the sample. We need to have an indicator, a KPI about the quality of the sample. Then we have this impact also for the organization of the emergency department. We have impact on the lack of recent medical history, making the result from blood gas analysis crucial for rapid clinical decision making. One of the causes for the increased length of stays in the presence of hemolyzed samples, when the physician found not correct value, usually repeat the sample, repeat another blood collection, and perform a lot of samples. For that reason, when we have hemolyzed sample, we have impact in the emergency department for the length of stay of the patient inside and the emergency department, and can delay also for the patient to go inside the hospital or to go outside. The implication of hemolysis for patient care and management, we have different levels of implication. We know that in clinical chemistry that usually hemolysis is a primary cause of unsuitable samples, and is the principal in clinical chemistry, in hematology, in coagulation, And also we have published a paper in Blood Gas some years ago about that we have a lot of levels of hemolysis sample for the blood specimen. Thus, hemolysis is the principal causes of additional cost for the laboratory, cost not only money, but also time. Time for the patient, time for the personal, time for the patient. And absolutely, also we have required further intervention on the patient. Increased decision-making times and delayed treatments lead to a longer hospital stay, thereby putting a strain on the entire unit. Then the management of hemolysis is a key component today in the evaluation of the point-of-care system. And also we have to evaluate how it's possible to organize this task. Nowadays, the common practice in managing hemolysis is to perform visual inspection after centrifugation. Usually, we perform centrifugation in the lab and we are able to check the color of serum or plasma. And if it's red, change the color from yellow to red. We know that we have inside hemoglobin and also we have hemolysis. But this system is difficult to perform for all kinds of sample, for the huge amount of sample. For that reason, clinical laboratory prefer to introduce hemolysis index. Because is a more objective measure, we perform on clinical chemistry by using spectrophotometer that are able to measure the free hemoglobin in plasma by using a spectrophotometer by absorbance of specific wavelengths. Nowadays, we use in clinical chemistry for all samples where we need to perform tests on plasma cell hemolysis index. But for hemolysis detection in blood testing is quite difficult. Why? Because usually in complete blood, for arterial blood, for point-of-care testing, is not possible to centrifuge the sample. And now, what is the benefit by using hemolysis detection? Absolutely, we have good quality sample. The most important things is that we have more accurate results because we ensure reliable readings of key parameters, not only potassium, but also hemoglobin, some kind of creatinine, but also we have ions, and we have carbohydrates. Another important task is we improve the safety because we reduce the risk of incorrect treatment. Because sometimes we have false hyperkalemia. When we have high level of potassium, usually clinical physician or medical doctor perform some kind of treatment, especially in critical ill patients. For that reason, if we have hemolysis detection, we are able to have better, good quality of the treatment for the patient. Absolutely fast and more effective care by identifying hemolysis early. Clinician can trust blood gas result, timely and appropriate intervention that improve patient outcome. Absolutely, we have a benefit for quality management because if we have hemolysis detection, we are able to satisfy some kind of accreditation requirements. And also we are able to align PAACC process with central laboratory practice because usually in clinical chemistry, we perform hemolysis detection for all kinds of samples. For that reason, there is some kind of solution, the hemolysis detection in blood gas testing. What is important? What is important for us? I remember 10 years ago, we published a paper in which, in clinical biochemistry, in which we check the amount of hemolysis sample on arterial blood gas, and we found around 10–15%, but we need to centrifuge all the sample. Well, this is impossible. Absolutely, we need integrated detection because we are able to ensuring PAACC device can flag or adjust for hemolyzed sample in real time. What is really important is to have this information for the physician because we need to have a flag that we can evaluate if they have hemolysis inside the sample. It's really important because if we don't have a good quality of sample, we have not good quality results. Obviously, there is another important task about the standardized protocols. We have to develop a specific protocol or recommendation to manage hemolysis in POCT. Align common laboratory practice with POCT blood gas testing to ensure better patient treatment. Standardized protocol and standardized operating procedure is essential for the good of the quality, for the good laboratory management. Then the management hemolyzed sample, what we can do for some kind of recommendation. Absolutely, we have to ensure training on proper blood draw technique to minimize in vitro hemolysis. The blood draw technique is absolutely important, and we need to give more time on the training of the personnel. We have also to introduce integrate hemolysis detection system with blood gas device. What is better is to have inside the blood gas a system able to measure if we have hemolysis sample or not. Moreover, what we need is to have automatically flag. It's really important that for the people that work with POCT to have a flag to evaluate the amount of hemolysis and clear protocols for handling and reporting hemolyzed sample to avoid misinterpretation. This is really important because usually the information from blood gas go inside the laboratory information system and the patient record. It's really important to have this information inside the electronic system. What is some ideas about the hemolysis index automatic? Absolutely, we need to have some kind of degree of hemolysis. For example, known, middle, moderate, just to have an index. In clinical chemistry, some kind of instrument have this kind of scale from 0.9, 0.5 scale is a semi-qualitative scale. And this is really important to have a scale inside. Moreover, we need to have some kind of information about the most important analytes that are influenced by hemolysis. For example, we need to have a flag for potassium results. We need to have a specific message for POCT users. And also we need to have a management of message on the laboratory information system for standardizing patient report. Nowadays, all the information go inside LIS and also go inside the patient record. For that reason, for accreditation program, for standardized operating procedures, we need to have a clear message and codified message. This is really absolutely important. Now you'll see that hemolysis is an underestimated important task in clinical chemistry. We have started to work a lot of years ago on hemolysis in clinical chemistry, in hormones, because we know the influence not only of free hemoglobin, but also about enzyme and ions that are inside the red blood cells, because we know nowadays that these analyte, hemoglobin, and other can influence a lot of the tests of clinical laboratory parameter. And this is also important for point of care testing, because until now, little is known about the quality of blood sample that we use to perform before analysis. Absolutely, the pre-analytical phase is an important task that we need to, because we know that in the pre-analytical phase, we are around from the 30 to 60% of the errors during the total turnaround time of the sample. The impact on potassium is clear because misleading results can affect patient management, especially in acute care. In acute care, we need to know the quality of the sample. It is important to have a flag that are able to underline the importance of the hemolysis inside. We need for detection impurities in point of care test because hemolysis detection is essential for ensuring accurate results and maintaining clinical safety, especially in the emergency department, where time sensitivity tests like blood gas have a rapid impact on clinical decision and patient safety. What we see in the future? Absolutely, we need to focus on better hemolysis detection technology and continuous staff training to reduce error. What is really important is focalized attention to have new detection systems that are able to perform hemolysis detection during the test and able to give flag on the results. Another important task is the training of the staff. Absolutely, the training and education is another important task to reduce error. Thank you very much for your time, and I like give the next presentation to Professor Christian Neff that they talk about the impact of undetected hemolysis on patient care in the emergency department. Thank you very much.
Thank you, Dr. Salvagno, for that presentation. My name is Christian Neff. I am a practicing emergency physician. I practice primarily in a large referral center based in the Intermountain Healthcare System, but I also practice in a variety of other settings, including community emergency departments and even rural emergency departments. I'm currently serving as our Chief Medical Officer for Utah Emergency Physicians. And so in that role, I have the opportunity to oversee clinical care provided throughout 7 departments. We'll have an opportunity today to discuss the impact of undetected hemolysis on patient care in the emergency department. So potassium is the electrolyte that gets all the attention. It's the one that makes sodium and chloride and all the other electrolytes jealous, honestly, but for good reason. Disorders of potassium are common. We also know that disorders of potassium, both hyperkalemia, that is elevated potassium, and hypokalemia, that is low potassium, may be lethal. In the background to the slide, you see the ominous sine wave that precedes death in patients with severe hyperkalemia. Potassium is also important, or just derangements in potassium are also important because symptoms are often vague, and particularly early on in the course, are often nonspecific. And then the treatment for both hypokalemia and hyperkalemia is costly, time-consuming, and intensive. So the indications for point-of-care potassium testing in the emergency department are very broad. There's never a day that goes by in clinical practice that I don't ask multiple times for a stat point-of-care potassium level. So we use potassium levels in metabolic emergencies such as DKA, in essentially all patients with kidney disease, either acute kidney injury or chronic kidney disease, in patients with vomiting and diarrhea or dehydration from other causes, in patients presenting with neurologic complaints such as seizures, coma, or confusion, in elderly or medically frail patients presenting with generalized weakness, in cardiac presentations such as arrhythmia, syncope, acute coronary syndrome, and in patients presenting with palpitations. And essentially any resuscitation patient will require a point-of-care potassium test. To understand the importance of potassium and undetected hemolysis in the emergency department, it's important to understand a little bit of the basics of potassium physiology. So potassium moves in and out of cells, and it's actively moved into cells by a sodium-potassium exchange pump. So the vast majority of potassium resides intracellularly. And then small changes in extracellular concentrations can have really profound effects. Small changes in extracellular concentrations can have drastic effects that are seen on the cardiovascular system. We see arrhythmias, both atrial arrhythmias, ventricular dysrhythmias, bradycardias, and also in the neuromuscular system with sometimes really profound presentations, including paralysis. And a normal potassium level is generally 3.5 to 5.0. So hemolysis is the rupturing of red blood cells, which then releases their high potassium contents into the extracellular fluid. Hemolysis comes in two types. There's in vivo hemolysis, meaning occurring in the body, and more commonly in the emergency department for our clinical presentations is in vitro hemolysis occurring after blood draw. And in vitro hemolysis results in spurious elevations in potassium known as pseudo-hyperkalemia. For a variety of reasons, hemolysis is common in the emergency department compared to other care locations. Some studies have found that hemolysis rates in emergency department populations approach 30%. And there's a variety of factors that contribute to that increased hemolysis in the emergency department. First, many of the patients are simply difficult to draw blood on. They can be obese, markedly dehydrated, in extremis, at extremes of age, history of injection drug use. And so many times patients are just very difficult to draw blood from in the emergency department as compared to other populations. In the emergency department, there are also often many different operators. Blood can be drawn by phlebotomists, techs, nursing, and there's often sort of rapid turnover in the emergency department with sometimes fairly varied training. And then also in the emergency department, most patients have an IV started rather than just venipuncture. But for all of those reasons, we see markedly increased hemolysis rates in the emergency department as compared to more controlled care settings. It's interesting to note that many clinicians and even laboratorians do not recognize a current blind spot as it relates to hemolysis detection in point-of-care testing. So I practice among 140 partners in our group, and they're superb clinicians committed to patient care. And if I were to survey my partners, I would imagine that only one or two would recognize that current point-of-care platforms do not include hemolysis detection. And that knowledge gap can extend even to laboratorians. After returning from a recent WRFN conference, I ran into our hospital laboratory director in the physician lounge, and she's a brilliant pathologist who's our general lab director. And I mentioned to her my concern about current point-of-care testing not having hemolysis detection. And I was surprised when she noted that this was the first time she had ever really considered the issue. So certainly clinicians and even general laboratorians may not really be aware of this point-of-care hemolysis detection blind spot. And so in our current practice, we without hemolysis detection, we rely on an imprecise clinical gestalt, or we find ourselves waiting 50 to 60 minutes for central lab results to return. And we find ourselves frequently in a period of uncertainty where we're forced to redraw and retest. This study is illustrative of the problem facing us in the emergency department. So in this study, the authors took 3,000 or so emergency department patients and looked at those that were diagnosed with hyperkalemia on point of care testing, and then compared those samples either to a redraw within 90 minutes or to a simultaneous blood draw that was sent to the central lab. And a couple of quotes from their conclusions I think are noteworthy. They found that the incidence of hemolysis in the emergency department point of care testing is high and difficult to detect. They found that in its current state, the incidence and inability to easily recognize sample hemolysis creates a level of uncertainty for providers and patients when point of care testing is utilized. A clinical case that illustrates the problem, and this is a clinical case that plays out over and over in emergency departments so that every emergency physician is familiar with a case like this and will have encountered one recently. So a 78-year-old woman, medically frail, history of chronic kidney disease, presents with generalized weakness. Her point of care potassium level returns as 6.5. Noting that that's potentially life-threatening, you launch into intensive, expensive, and time-consuming treatments, including treatment with IV calcium, insulin and glucose, and sodium bicarb. The patient requires continuous telemetry monitoring, one-to-one nursing, and you prepare for admission to the ICU. You then find that the central lab results are available in 60 minutes or thereabouts, and they reveal only a mildly elevated potassium level and a hemolyzed sample. So in this case, like many others like it, this unrecognized hemolysis has resulted in unnecessary treatments that have potential harm, delays in care, and increased costs. Undetected hemolysis has many different adverse effects. We have just illustrated some of the adverse effects on clinical care. However, there are also delays in the delivery of care. They're with increased throughput times. The treatment for both hypokalemia and hyperkalemia is time consuming. Undetected hemolysis also potentially results in increased costs through unnecessary transfers and admission. And the treatment of hyperkalemia and hypokalemia requires nursing resources, requires continuous telemetry monitoring, requires ED or ICU level care. In this study, the authors mentioned earlier reported out some specifics. They noted that in this study of patients with hyperkalemia in the emergency department, approximately 40% of these patients with hyperkalemia on point of care testing had a degree of hemolysis when they compared to redraws or to central lab testing. Most importantly, they reported that 11% of these patients required a change of care. So they noted that the effect of undetected in vitro hemolysis was frequently clinically significant. So as we've noted previously, undetected hemolysis in the emergency department is also potentially associated with prolonged emergency department throughput and delays. And in our current climate of chronic ED overcrowding and delays, this is a really important issue for providers, for patients, for administrators. But in this study, the authors found that that when they compared patients with hemolysis versus those without, they found an average delay in throughput of 62 minutes. They found that patients with hemolysis had an increased length of stay of 62 minutes when compared to patients without hemolysis. And they found true that this increased length of stay held true really across patient severity of illness and also across both patients who were admitted and discharged. And point of care hemolysis detection then has the potential to minimize delays in throughput. Hemolysis detection at the point of care is a true game changer. The GEM Premier 7000 with integrated hemolysis detection promises to bring laboratory certainty and quality to the point of care. For a practicing emergency physician, the ability to have certainty with regards to the potassium level at the point of care is a game changer. It improves clinical quality and certainty, it improves emergency department throughput, and it makes all the difference to patients and emergency physicians. Thank you for your time today. We look forward to hearing from Dr. Hoppenz next.
Yeah, thank you, Dr. Neff, for this presentation over here. So I'm taking over. My name is Marc Hoppenz. I'm a pediatrician and neonatologist working in Cologne in Germany and being the head of the department of a large perinatal unit, a large NICU. What I'm talking about today is hemolysis in the NICU and some problems which arise in this environment for the patients who are looked after over there. So in particular, I'm looking at the extremely premature infants. So we're looking at infants with a gestational age between 22 and 24 weeks. And they are particularly vulnerable. That's the reason why we were looking into them. If we have a quick look at the outcome of those infants, we have a large study from the USA and Canada, from the NICHD network. And what you see over there is that the survival rates are quite low. So with 22 weeks, we are with survival rates between 3 and 19%, going up to nearly 50% with 24 weeks of gestational age. And even worse are the data for the outcome of the survival without a profound impairment. So as you can see over there, so in the best case, with 24 weeks, we get about a third of those infants survive without profound impairments. What we do have is data down there from our NICU, and over a 10-year period. And what you can see is that the survival rates have improved over time. And in our NICU, so we reach survival rates of up to 80% for those infants. And what I'm quite delighted to report is that the survival rate without profound impairment is much better than the above data. So about half up to 2/3 of those patients survive without profound impairment. Just to give you a quick look at the what we're talking about and what sort of children we're talking about and what the outcome might be. What are the problems in those extremely premature infants? Well, I'm concentrating on some aspects of that. They do have a high transdermal fluid loss, so fluid requirement up to 300 mils per kilogram per day. So that's quite a lot of fluid, because they lose this fluid via the skin. The skin is very, very thin, and it's not really a barrier for fluid loss. The kidneys are immature and therefore not working as in older children. And we do have a risk of non-oliguric hyperkalemia, which means that even without giving the infant any potassium, the potassium in the serum might rise up to 7, 8, or sometimes 9 for no obvious reason, really. So we do have a high risk of electrolyte disturbances. That's one aspect. The next aspect is that the brain, and we were talking about impaired neurological outcome, that the brain of the infant is very, very sensitive to any changes. We do have an immature regulation of cerebral perfusion, which is entirely pressure passive. And we do have an immature brain with very, very thin-walled blood vessels. And that leads to a further problem that we have, that those infants are at a very high risk for cerebral hemorrhage, especially during the first 3 days of life. And on the other hand, they have a very high risk of cerebral hyperperfusion injury. So if the blood pressure drops, the cerebral perfusion drops, and this can lead to injury in the developing brain. And what that looks like, the brain hemorrhage or hypoperfusion, you can see in those pictures down below. You can see there on the right side, which is the left side of the infant's brain, you can see that there is a large irregular mass, very bright, and that is blood, and with a severe damage to brain structures. On the right-hand side, you can see like holes in the brain, and this is hyperperfusion injury, largely hyperperfusion injury, where cerebral tissue has been damaged. So we will try everything to avoid that. And how can we avoid that? We need to avoid that the cerebral perfusion is very high, or that the cerebral perfusion is too low. So we need to keep the patient from anything which will result in changes of blood pressure. And we call that a minimal handling. So we do as much as is needed, but as less as possible, and we need minimal handling. Right. Having said that, we come to a patient's case, and that is Julian, and I'm allowed by his parents to introduce him over here. He came to us with a gestational age of 23 weeks after choriamnionitis with a birth weight below 500 grams. And we needed to intubate and ventilate the patient. We gave surfactant, which is pretty routine in those infants. We inserted a central catheter from a peripheral vein and admitted him to the NICU and had him on mechanical ventilation. What happened then was that after 28 hours of life, he developed a hyperkalemia with a potassium of 7.1. So what does that mean, or what are the implications of that? This hyperkalemia is endangering the patient, and by paralysis, by bradycardia, by disturbance of the heart rhythm, and leading to, in the worst case, of asystole. And so we need to treat that. So what is the treatment? That's the most frequently used treatment. We treat them with insulin and glucose, and in order to get the potassium back into the cells and get the potassium level in the blood lower. The risk of this treatment is hyperglycemia, which has a very high risk for cerebral hemorrhage, or hypoglycemia, which also has a potential for cerebral damage. And furthermore, we need to check the blood sugar quite frequently, and that is very much opposed to our concept of minimal handling. So, talking about blood sampling in premature infants, what sort of possibilities do we have? We can do a venous puncture, but unfortunately, in those infants, we have a very limited number of peripheral veins. We can do an arterial puncture, and once again, the number of peripheral arteries which are accessible through puncture is limited. We can draw that from an indwelling umbilical vein catheter, which is quite frequently done. But the problem of an umbilical vein catheter is that there is a risk of infection, of bacterial colonization, and a risk of thrombosis. That's why we aim at avoiding leaving an umbilical catheter in. The alternative is draw from an indwelling umbilical artery catheter, as you can see down there. And the problem here is, you get arterial blood, which is perfect for measuring all sorts of parameters. But the blood sampling from such a catheter results in cerebral hyperperfusion during the procedures. And there are very good publications about that. And you can see them, they're mentioned down there, especially from Claudia Roll. So we want to avoid cerebral hyperperfusion. So what options are left? Well, the option which is left is a capillary heel prick, which is frequently done in our unit and many NICUs in, at least in Germany, but I know worldwide as well. And we have a problem with the blood, which is collected by capillary blood sampling, that not all parameters we measure are really reliable. We do have a good correlation between capillary and arterial samples for parameters like pH, like sodium, as you can see over there, even for lactate, the correlation is quite good. It's not good for the oxygen saturation, for the chloride, and in particular, the correlation is not good for the potassium. You can see that down there. So if we take a capillary blood sample, the potassium measurement is highly unreliable, and that is due to hemolysis. Well, the amount of the changes through hemolysis is shown over here. What you can see there, on the x-axis, there is the degree of hemolysis, and on the y-axis, there is the potassium level. And what you can see is that the higher the hemolysis is, the higher is the potassium. And this is particularly true for capillary blood samples, a bit less for venous blood samples as well, but in particular for capillary blood samples. Right, so coming back to Julian with the potassium of 7.1, what is what are we doing about that? If we have in our unit a potassium which is above 6.5 millimoles per liter, the first thing we do, especially when it's a capillary sample, is we repeat the sample because we don't believe it. So if possible, we repeat the sample with venous or arterial blood sampling. And depending on the value then over here, and you can see this, are we acting? So if it's above 7 millimoles per liter, we're starting to treat with insulin as glucose, as mentioned earlier. If it's between 6.5 and 6.9, we will check it within 1 hour and then frequently, because it's still critical. And if it's below 6.5 or up to 6.5 millimoles per liter, when we check is dependent on the clinical situation. So we need a repeat blood sample to start with and go from there. Now, if we had the possibility to report hemolysis, knowing what degree of hemolysis is in the sample. This does have an effect on a workflow in hyperkalemia, because mostly we wouldn't need to repeat the sample, but act according to the potassium level and to the degree of hemolysis. If it was above 7 millimoles per liter and it was grossly hemolyzed, we would relax a little bit and say, okay, that's the reason for this high potassium. We don't need to start treatment. But even in the first sample here, over here, if we see it's not hemolyzed or only to a minor degree hemolyzed, we would start treatment right away. In the area between 6.5 and 6.9 millimoles per liter, if it was not hemolyzed, we would do, as mentioned before, check it frequently and check it within 1 hour. But if it's grossly hemolyzed, we're safe in the knowledge it is not in a critical area, and we can check that according to the clinical situation. So that would be hyperkalemia. There is another case I will want to briefly show you, and this is the case report of Anna. You can see that right here. She's 23 weeks as well, and unfortunately developed renal failure due to a patent ductus arteriosus, which was operatively closed. And after that, fortunately, the kidney started working again, but she went into a polyuric phase with a very high diuresis and losing quite a lot of water. And maybe not only water, but the capillary blood gases revealed a potassium of 3.7, and well, it's a bit on the low side, but it's really nothing to worry about, you would think. But when you take the venous blood gases, shortly afterwards, we found that the potassium was 2.5 millimoles per liter. So very, very low. And a potassium between below 2.5 millimoles per liter results in muscular weakness, can result in cardiac arrhythmia as well, and does have a possible impact on the spontaneous breathing and on blood pressure. So we really want to avoid that. And what we have to realize is that those capillary blood samples here with a potassium of 3.7 was due to a hemolyzed sample. And, this was masking the fact that Anna had a very, very low potassium and a dangerously low potassium. So what are the benefits of hemolysis reporting in the NICU? Well, for the patient, and you could see that in the first case report, we can reduce the number of blood samples we take from extremely premature infants, thereby reducing the iatrogenic anemia. We can reduce the effect of blood sampling on cerebral perfusion by causing less pain and by not taking blood from an indwelling arterial catheter. It does support the minimal handling. We avoid any side effects of a possibly unnecessary treatment for hyperkalemia, and we can detect hypokalemia earlier. For us as neonatologists and pediatricians, there's the advantage that the level of uncertainty we have with any capillary sample, or in a matter of fact, the venous sample, is reduced. And this leads to a peace of mind. So this is a huge step, in my opinion, into the right direction. And with that, I'm ending my presentation over here. I thank you for your attention, and I'm delighted to introduce you to the next presenter, which would be Danyel Tacker. Thank you very much.
Thank you, Dr. Hoppenz, for that talk. And hello, I'm Danyel Tacker, and I am a clinical professor at West Virginia University in Morgantown, West Virginia. I have several roles in the laboratory. One of them used to be blood gas direction, and I have been handing that service over to a protege in the last few months. So I was involved in this project and am very pleased to be here to talk about it. So there are two discussions that we're going to have that overlap briefly. One is to talk about concerns that we get when hemolysis goes undetected at the point of care, so in near patient testing. And then also to discuss the benefits of adopting technology that can detect hemolysis in that setting. So these, of course, weave together and have a lot to do with quality, safety, and reassurance. When we are looking at sources of hemolysis, there's in vivo and in vitro hemolysis. And when we talk about in vivo hemolysis, there's a number of things that clinicians are well aware of that can cause this. You've got burn patients who are hemolyzing, cardiopulmonary bypass patients frequently have hemolysis, and then hemolytic anemias, patients on ECMO might have mechanical disruptions, things like that, things that the laboratory cannot control and cannot prevent. Then there's the pre-analytic or in vitro sources of hemolysis, and there are many of those. Actually, they can be linked to a number of things, including how the patient prepares for phlebotomy, if they have that chance. In the near patient setting, they often don't. But how the specimen is drawn, the idea of making a fist or drawing through a line or doing these other things, depending on how a specimen is transported to the laboratory, hemolysis can occur. And then in some steps of specimen preparation, hemolysis can occur. In the near patient setting, you usually don't have a lot of specimen preparation because it's usually whole blood that is just tested. So, the give and take of hemolysis is that it depends a lot on the circumstances that are involved in getting that specimen to a testing site and getting the testing performed. And when we look at degrees of hemolysis, we go from basically 0 to grossly hemolysis. So nothing there versus a whole bunch. And in the laboratory, in the central labs, we've known about hemolysis for a long time. We have mechanical and automated means of detecting hemolysis, and we have for years. So we're able to say which tests are sensitive to a slight hemolysis versus a mild, moderate, or gross. In the central lab, we're well accustomed to having those conversations with providers and saying, I think you might need a new specimen for this. Or if there's an in vivo hemolysis, this is going to be impacted. We're able to do that there. However, what we use that knowledge for and applying it to the point of care and near patient testing is we know that point of care specimens are also going to have some rate of hemolysis. In the central lab, it's about 1 in 1,000 specimens that we have that is so impacted that we have to reject the specimen. But we aren't really sure how broad that scope is in the point of care setting. It could be a lot, it could be minimal. So we're not sure, but we know it's there. We also know that it's not a central lab problem. All the laboratory techniques are susceptible in some way to hemolysis, either through interference with the method or through an actual release of those targets from an erythrocyte. So we're aware of these things, but we just don't know how to detect it in whole blood so well. And we haven't had point of care devices to date that can detect hemolysis. So we haven't really had tools to get us to that next step. So when we're working in the world of quality and we're working in the world of clinical reliability, we have to work with knowns and unknowns. Thing is we've already talked about what we know. We know hemolysis exists, but we don't know the scope. So that's that known unknowns. We know that we don't know the extent of this problem. And the unknown knowns that we get from this are that we know we have tools at our disposal and we know we can have conversations, but we have to know where to apply them. I hope that makes sense. But we are operating in this realm of uncertainty, and the lab is always trying to shrink it. So that's always our goal, is to increase accuracy, precision, and how we have these conversations with clinicians. This is why we always advise when you're using point of care testing that if you can compare it to the central lab occasionally, it's a good idea, because we're living in the world of knowns over there, and we can say we know what happened in that specimen, so point of care is probably being impacted by it. That is changed at our institution. And before I tell you how it changed, I'll tell you how we're set up. Institutions have different layouts for blood gas testing, and this is the realm where we've gone into hemolysis detection in the point of care and near patient testing is through blood gas, through the Werfen GEM 7000s. We have a centralized blood gas laboratory in the main hospital with 5 analyzers. Those were swapped out from 5,000 to 7,000. So no hemolysis detection to hemolysis detection. We have an attached Heart and Vascular Institute that bought into point-of-care based blood gas testing many years ago, and they have 9 analyzers just in their unit. They love these things, so they use them a lot, and we're very pleased that they like them. Then we built a children's hospital a few years ago and added blood gas testing there because the walk is so far. Even though the buildings are attached, you don't want to be walking from the children's over to the blood gas laboratory in the main area, so we placed some there too. The Children's Hospital blood gas lab also got 7,000 swapped in because of our association through service lines. So we have 2 locations that have the 7,000s and 1 location in our hospital that still is on 5,000s. So when we undertook this project with Werfen, we were invited to test out the 7,000s, test out the hemolysis detection feature on the blood gas analyzer, and implement it. And this sounds simple, but it actually took a lot of conversations with our ICU leads, with the providers that are going to be reading results. We said, what do you need to know? What do you want to see? Because we're going to be reporting this now. On the right at the top, you see the report that we give from a blood gas with the electrolytes that is not hemolyzed. So it says none. And nothing is flagged that is associated, and only the potassium right now is associated with that. The linkage that we give in comments is educational because of those conversations with the ICU leads and the providers. We want to know how much impact we are going to get when you suggest that we get a new specimen, and this would always be in the report. Therefore, this is a set that's been posted, whether it's none or, like you see on the bottom of the slide, a grossly hemolyzed specimen with a non-physiologically high potassium, but at least it's been reported, probably because the team needs the other results. They at least know that there's a marked increase in potassium because of the hemolysis in this specimen. So there is at least contribution from hemolysis, whether it be in vivo or in vitro. So we add these comments, and we tailored this so that the person could get a quick visual index of what's going on with hemolysis and potassium relative to each other. And then also there's some guidance in the result comments that we've placed. So from this, we can gather all sorts of data now. Because we've embedded hemolysis resulting in the reporting, we can give out quality data by the unit, by the patient, by the collector, or by the type of specimen. So if we have a patient who's in the ECMO unit and they're getting frequent hemolysis, we're pretty sure we know why that's happening. But if we get a cluster of gross hemolysis in a unit and we find out that they're different patients, is it the same collector? Are they new? Do they need more training? These are things that we can ask questions about. So we can say, we can finally answer the question about scope. How often are grossly or moderately or mildly hemolyzed specimens coming into us? What can we do about it? And very importantly, how often have you gotten normal potassium results in the past that came from a hemolyzed specimen that masked a hypokalemia? How many opportunities do you now have to intervene in a patient who's hypokalemic, but you didn't know it because of the hemolysis that was present? This is huge. This is giant for us in the laboratory to be able to help with that. So this is fantastic. And being able to practice, effect coaching, and move specimens through more efficiently, this is just a really big development for us. So since the switch, we have had the ability to learn more about hemolysis in the near patient testing setting. We are going to summarize data. We are going to publish. We are going to share this information. And I think publications are starting to come out. This is awesome stuff. But since the go live in March of 2024, so we're still looking at data, but we have objective and reproducible calls. When the blood gas calls, regardless of who generated the result, the conversation can be the same. And that's a good thing, because then the unit is familiar with the conversation. We can then improve what we're talking about and how we're talking about it. People get more quality minded about how the specimens are getting generated. So we can trend things, we can make dashboards and report cards and all those quality terms that people talk about. We can do that now in a way for hemolysis that we were doing before for clots and other things. And we can standardize across our system. So we have 24 hospitals. We have new opportunities to flip people over to this and expand that reporting, which is amazing. So, that's my brief talk about our project. I would be happy to talk more, but I want to thank some people in my final words here. Dr. Jian Yang who is my protege I mentioned earlier. He's now the director of blood gas, and I'm excited to kind of watch how they take this project forward. The folks below in the next line, Brad, Brian, Desiree, and Pete, these are our leads in respiratory therapy. So they made this happen. They did the validation and logistical work. They're the ones having the conversations every single month and looking at dashboards. So they're just amazing. The Werfen team, fantastic throughout the process. It was really great to work with them because we were really talking about how do we employ this? How do we deploy this? So it was very exciting, and the invitation to this webinar was also very gracious. And thanking you as the audience for attending this webinar, for listening to my talk. Thank you very much.